Hello, hello everyone. Welcome to the second Black Health Matters live stream event. My name is Phil Samba. I work for the Love Tank, which is a non-profit organization promoting the health and well-being of underserved communities. We have many projects at the Love Tank, and this event is part of the Black Health Matters project. Black Health Matters is a project funded by the National Lottery Community Fund, and was designed to address a number of different health inequalities faced by Black communities. Unfortunately, my colleague Dale, the coordinator of this project, is unwell, so I'm taking his place, and I really hope I do a good job. We know already that health inequalities exist across a number of different areas and disproportionately impact Black and Brown communities in the UK, with mental health being one of them. Mental health conditions disproportionately impact Black communities in the UK. And even though Black people have worse mental health than white people here in the UK, our white counterparts are more than twice as likely to receive support for their mental health issues. We have an incredible panel, and we're looking at misconceptions around mental health, challenges accessing mental health services, stigma, and so much more. So please feel free to ask any questions or comments throughout the event. And if we have enough time, we will address them. So let's welcome our guests. First off, we have Elaine Thomas, who is a community psychiatric nurse.
Hi, hello.
Hi. We have Jason Grant, who's a peer support worker at Early Intervention Services, but we're having technical difficulties, so we'll see.
I think I'm here. Can you hear me now?
Oh, thank you. Yes.
Okay, nice to see everyone. Good evening.
We have Sarah Atayero, a mental health therapist, and Matthew McKenzie, who runs BAME Carers Forum and is the editor of Caring Mind, an online mental health newspaper. So to start off with, I kind of wanted to discuss some of the misconceptions that people tend to have when it comes into relation to mental health illnesses, particularly psychosis. So by the way, I've mixed the questions up, so they're all there, but they've moved around on who's going to be asked what. Elaine, could you tell us like a brief description of what psychosis is, and maybe what some of the causes are for it?
Okay, thank you. So what psychosis is? Psychosis is kind of what we sometimes call like an umbrella term. So it encompasses quite a lot of different symptoms. So someone experiencing psychosis is not necessarily going to experience every one of these symptoms. Sometimes we think about it in terms of sometimes we call it positive and negative symptoms. And when we say that, we're talking about positive as in there's an additional thing happening with your senses. So it might be about kind of seeing things that other people aren't really seeing, or hearing things other people aren't hearing. Maybe it could be whispering, talking, could be sounds, and it often coming through as clearly as my voice is now to the people experiencing it. It could be about kind of other sensations. Sometimes people talk about crawling on the sensations on their skin, things like that, smelling things other people don't smell, or tasting things that other people don't taste. Oftentimes that's how people sort of tend to recognize it. Oftentimes there's a change in the way someone might perceive certain events. So people often talk about feeling particularly sort of persecuted in some kind of way. So sometimes people talk about feeling like there's kind of greater vigilance around them. Other people are talking about them on the bus or looking at them more, or that sort of thing. And on the other sort of side of things that people wouldn't necessarily relate to psychosis is things like feeling more anxious, having lower mood, struggling to concentrate, those sorts of kind of things that we kind of term it as negative symptoms, as in it's taking something away from that person in some way. And yeah, not oftentimes there's a kind of a lead-in period. So we sometimes call it the prodromal kind of phase of the illness, where you won't necessarily get sort of the hearing things, seeing things. You might get a lot more of the negative side of things, so the taking away, so the lack of concentration, the difficulty remembering things, the low mood, the low energy, that sort of side of things. And often there's that period, then there's a kind of a crisis at the end of it, where you start to get some of these kind of experiences that affect your sensations and your perception of events. Yeah.
And I guess, what are the causes of psychosis?
Really difficult to pin that one down. I think it's a multifaceted thing. One quite common model is to think about it as stress combined with a vulnerability. So sometimes when we're talking to people, we kind of frame it in terms of something called a stress bucket. And we think about all the things that happen in our lives that kind of rain down within this bucket to start to fill it up. So you might have kind of different stresses within your life, different people experience different things. And I guess in terms of Black people in countries with a white majority, there's a lot more racism, and that will come into the way in which we operate within our lives and the adversities that we then face and the stresses that add into our experiences. So there's other factors that affect it, like if you've had a past traumatic experience, if you've been bullied, if you are struggling with homelessness or unemployment or any other sort of everyday stresses as well, piling in. And then we think of the kind of the psychosis of the overflowing of the bucket. So all those stresses combined as one can lead anyone into an experience of having psychosis.
It's interesting you use the stress bucket. I've never heard of it like that, but it makes perfect sense when you say that. And,
I'm glad it makes sense.
Jason, I'm going to come to you next. I guess during the introduction, I was saying that us as Black people, we have the highest mental health needs. We have low engagement when it comes to mental health services. Why do you think that is?
Yeah, so it's a really big question. As I say, thanks for inviting me on to kind of speak around these discussions. It's really important to kind of have these conversations, really. In terms of the need, I guess, and I can only speak from my own kind of personal experience here. So I didn't grow up in a household where talking was a thing. So we kind of learned to kind of, keep things, keep secrets quiet and not really talk about our emotions and feelings. And maybe, I don't know if that's me being a male or whether it was just my kind of cultural upbringing. But I didn't grow up in a household where talking was a thing. So any kind of challenge that I faced, I kind of just bottled down and bottled in my problems and kind of tried to deal with it myself. And that probably, if I kind of extrapolate that out to a wider community kind of perspective, it's probably an ongoing thing that still happens with young boys today. So I don't think many young boys are taught to be in touch with their emotions, be in touch with their feelings, and to talk about the problems that they're facing. In terms of engagement with services, I think there is a kind of branding issue, really. So before I kind of, so I've got personal experience of psychosis. And before I kind of entered mental health services as a patient, I had this perception about what to expect, right? It was this big, scary thing. People were going to put you in hospital, you'd be locked away, you'd be drugged up to the eyeballs, you'd be shuffling along, you would have no kind of awareness or consciousness of yourself. And that's because where I grew up in Southeast London, but so when I was growing up in the 80s and 90s, I saw mental health patients on the streets and they didn't look too healthy, right? So that was my kind of perception. When I actually came into services, actually you meet kind, compassionate. Well, I was lucky to meet kind and compassionate people who cared about my well-being and tried to help me make sense of my experiences. And actually, yes, there are some negative things that happen, usually around hospitals, I would say, but especially within community teams. Community teams are desperately trying to get people to live a meaningful life in the community. At least that's been my experience. So I think it's just a kind of our own perception. Maybe it's the media as well, the kind of films we watch, these horror films where, usually it's somebody that's a bit psychotic and all that stuff, all that association with newspapers as well. So maybe it's our own perception, but I think maybe mental health professionals need to do much better job of just, promoting themselves and being out in communities. And I really really liked what Elaine was talking about, around the stress bucket example as well. So I think the clarity and just being out in the community and speaking about what mental health is and how people can get the help and treatment they need would help to reduce some of that negative association, I would say.
Yeah, I relate to some of what you were saying about, growing up in a home and not, I guess, expressing the negative feelings. I feel like sometimes in Black communities, in Black families, it's like happiness is fine, but sadness isn't, or anything, anxiety isn't, or like we don't talk about those things, or those things don't affect us. So I completely relate to you saying that. Sarah, the most commonly recognized mental health interventions are typically talking therapies. So what do you think that Black people need to know about therapy?
It's a really great question. So from my experience of delivering talking therapies, I think across cultures, there's a big misconception of what that looks like. So what does talking therapy, how is it going to help me if someone's suffering with psychosis, which at its acuity is a really distressing and complex disorder where there's a lot of fear and there's a lot of pain? How can talking to someone for an hour be helpful? And so I think for talking therapies, I think the main thing is, how can they be helpful, and what is involved? And it's I think like Elaine said, it's such an umbrella term. Talking therapies covers a lot of different kind of approaches. The most common one that's used in the NHS is something called cognitive behavioral therapy. And this is about the relationship between thoughts, behaviors, and feelings. Now, there is a version of cognitive behavioral therapy specifically for psychosis. It's something I've delivered myself. And I think where the NHS is going towards is a really trauma-informed approach to talking therapies for psychosis, which is really important. I think, as both Elaine and Jason have already talked about, where psychosis might originate from is from kind of complex and really difficult and stressful experiences. And so part of talking therapy is kind of the validation of that. And kind of getting the person who's in front of you to recognize that this isn't their fault. They've gone through a really difficult time, and there are steps that they can take to kind of alleviate their situation alongside other forms of therapy in terms of kind of pharmaceuticals, medication that might be embedded within their care plan. So that's the first thing I'd say. Talking therapies is often, big question is like, how can you help me? But they can be really beneficial, and sometimes that space is really valued by the people that I see. And then I think in terms of Black communities specifically, sometimes there is a resistance to talk because of what you guys already mentioned in terms of culture and what we're used to. We kind of keep our dirty laundry at home and don't share with others, and so sometimes there can be that resistance. And so I think a big thing is confidentiality, and knowing that what you share in that space will stay with your therapist and maybe their supervisor, but it's not going to go out into the community. No one needs to know you're attending the services. Services are really flexible at the moment in terms of COVID. You can do therapy at home. You don't have to go to kind of a building that people know that people who are having psychosis or anxiety or depression go to that building, wherever it is. So I think that is something that's really important. And then one last thing I'd say is that it's difficult. It's not an easy process. It's not kind of talking about your feelings and just talking about it makes you feel better. Actually, sometimes it isn't cathartic. Actually, sometimes it's extremely painful, and you need someone to hold you in that moment. And I think that's a really important thing to remember, that it's not an easy process, but it can be a really powerful one.
Okay. Like listening to your answer, you made me think of a follow-up question, which is therapy only for white people?
That's a loaded question. I would say I would say the system and the way that it's set up, maybe yes, maybe it is just for white people, and the way that mental health services have been shaped historically, and the way that they have treated Black communities. I think Jason mentioned kind of growing up in Southeast London. I think some of my clients have said they grew up and kind of the word Maudsley was like a threat, you know, don't act like that unless you'll end up at the Maudsley. And, you know, it wasn't for talking therapy, it was to be sectioned under the Mental Health Act and given medication. And Jason, you described it really well. You talked about kind of drugged and, you know, you become a zombie. And, you know, at the end of the day, unfortunately for our communities, that's still happening. And we don't get the access to talking therapies that we should do. And even when we do get the access, we don't get the same treatment that we should do in comparison to other groups. We have lower, in terms of services, they call it kind of recovery rates, which is when someone comes to you with a problem, give them therapy, they might reach recovery. We have lower recovery rates. We have higher dropout rates from therapy because, like I said, at the moment, the system is not built for our communities. And actually what you see is that a lot of the services within the NHS, you'll see Black people who are wanting therapy going outside of the NHS. They might go to private therapists who are using non-Western approaches, maybe using more African-centered approaches, using more trauma-informed approaches. And it's not about having a Black therapist because you're a Black person. That's not the important thing. It's just someone who is aware and is responsive and who is curious. You don't need to be Black to treat someone who's Black, but you need to be kind of culturally competent and aware. And unfortunately, in the NHS at the moment, that is severely lacking.
I have to say, I agree with everything you just said. Wow, it's really interesting. I kind of wish that I wasn't hosting so I could watch what after keep going, ask questions and stuff, and the stuff I want to say, but I'm gonna hold back. Matthew, I'm gonna come to you next. So I guess we were just talking about talking therapies, and sometimes talking therapies can be greatly stigmatized. And I feel like there's sometimes a bigger stigma when it comes to taking medication for mental health issues, with medication sometimes being seen as like an extreme measure. Where do you think this stigma comes from?
Yeah, thanks for having me. And, you know, really important question because I was a former mental health carer, caring for my mother, you know, obviously struggling in a sense to aid in recovery. And one of the big tools for that was medication. I'm going to try and be brief. I mean, obviously being brief doesn't do the topic justice because I know there's so much, there's only so much can fit into this event. But obviously it's the side effects is one of the things. When you see, you know, when my mum ended up in the ward and she saw other patients, you know, Black, white, feeling really unwell, obviously part of it is mental health issues, but also the medication, you know, someone was just drowsy, drooling, still don't even seem that well enough, and lacking, you know, obviously the therapy, the talking therapy. And over the years, my mum experienced the same things. In fact, there were so many changes in her medication, even when I requested a change, because as a carer, you can see the effect it has on your loved one. It's tragic. It really is. So I do understand why there's stigma and people just don't want it. They just don't want something else. And unfortunately, the evolution of medication needs to go further. There needs to be a lot more research on medication. Obviously, it's not the only tool in the box, but it's a very important one. I'm not against it. But it's important. There's other things. I'm going to be as brief as I can. I mean, let's look at the mortality gap. Obviously, people are dying, you know, service users and patients are dying far sooner, and it's got to be down to the medication. Mum died, you know, fairly young in her age, and I knew that if it wasn't for the illness, she would have lived a lot longer. So this is obviously why, you know, I'm doing events like this, speaking as much as I can about how it can affect families and carers when you see your loved one's life just slowly, you know, drifting away. Not just the life, but what's the word for it? The quality of life, really. So it's not just, you know, recovery, it's the quality of life. Once they give them the medication, the quality of life goes way downhill if it wasn't a struggle before they became mentally unwell. So there's loads of things. Also, the poor experience of the mental health system poor experience of sectioning with the police as well. It's not just the mental health system itself, it's other factors. Understanding how the mental health system works, engagement from that. That's why I set up that forum to help educate others, not just Black people, everyone that, especially families and carers who want to understand, why their loved one is struggling with the system, and it affects them as well, affects carers as well. So I think I'll keep it at that, because I'm sure there's going to be lots more interesting answers. But I think it's an important question, and it needs more research as well, needs more explanation, and people need to come together to understand, these devastating issues that hits the Black community or the ethnic community as well.
I'm sorry to hear about your mom as well. I feel like I feel like sometimes we as Black people are a little bit of a disadvantage when it comes to mental health, because it's just I think things are a lot more stigmatized overall in terms of talking therapy, medication, and just even having a general awareness of what services or what things are available to us. I'm going to come to Elaine first and then Sarah again, but I want to ask about Black women. So Black women have the highest rates of common mental health issues, such as anxiety, depression, and OCD in England. What do you think the factors are that contribute to this? Oh, sorry.
Sorry, but yeah, I realised I did it again. Apologies. I guess it's kind of, I think it's really important to realise the context in which kind of Black women are living. I guess there's a lot to think about in terms of the adversities that people face just by being Black in the UK. It means kind of the experience of poorer housing, higher levels of unemployment, poor pay sometimes. But with women, there's the intersectionality of the fact that they're also disadvantaged by being kind of women in this in the UK too, and that again kind of really doubles down on kind of the employment opportunities, pay. Oftentimes women are main carers. Oftentimes that then limits what they're able to be kind of exposed to, job opportunities, availability to do other kind of things. Sometimes women are subject to kind of, domestic violence in higher rates than are men. So I can see how these things together can contribute to kind of higher rates of Black women accessing, kind of having to access services or being diagnosed with illnesses. And I guess there's kind of, you can't really escape the structural racism, the institutional racism that are systems in which we operate in, particularly in a white majority country. And it's hard to then separate that from the other experiences that we then go through, or the way that policies are structured without thinking of us and without us necessarily in mind. And there's something in there about kind of women being believed when they say that something's happening, or they say they're going through something, and the way it's then understood by the person, the professional or whoever that they're speaking to, and things being misinterpreted, and that being down to someone's more so than to someone's judgment and perception rather than their actual understanding of what that individual person is going through. Yeah.
Okay. And Sarah, do you have anything to add to that?
I think Elaine summed it up really, really nicely. I think your last point about being believed is a really, really important one for Black women. And I think a really good example of that is Black maternal health, or Black maternal mortality, actually, where Black women are dying during pregnancy at much higher rates in comparison to any other ethnic group. And it is time and time again, you will hear that the woman was complaining that she had pains, whether it was earlier on during the pregnancy, whether or not it was during labor, and not being believed. And so whether or not it's as severe as, you know, a black woman passing in labor, or just the traumatic experience of labor is traumatic enough, but to have that, to be going in severe pain and not believed, the mental health consequences that are of that, it's no surprise that there are such high rates of depression within Black women. And it reminds me of a quote I saw earlier by a professor of sociology. Talks about how race is not a biological category that naturally produces kind of genetic differences and higher rates of mental health, whereas actually it's a political category, and because of the social context and the social inequality, it reduces people's health. So it's not that the mere fact of us being Black means that we're going to have higher rates of mental health. It's the structure, that the system that we live in, like Elaine talked about. When we live in white dominant, racist, institutionally racist cultures, we're going to have higher rates. And unfortunately for Black women, we don't only live in a racist society, we also live in a sexist society, in a patriarchal society, which kind of doubles down almost, I know that's not the best term, but doubles down on the discrimination that we experience.
Wow, like you're spot on. I think it's important to think about the intersection when it comes to mental health, especially when it comes to women. I guess I'd like to come to Matthew first, and then Jason. But following the question about Black women's mental health, we do see a similar trend with Black men's mental health. They are actually 10 times more likely to experience psychosis than white men. Why do you think this is the case? And why is it specifically psychosis?
I think some of the themes Sarah's mentioned, I certainly can agree with. With Black men, I think in general, I suppose it might be seen controversial, but I can only speak from my own experiences, and they just don't want to talk about it. And with men, you have to sort of, there's this sort of tough persona, I suppose, that I'm not gonna talk to my peer groups regarding about me crying at night over watching some movie. So and I suppose it does seem funny, but unfortunately the outcome is when, as a young Black man, or whatever, when things really do get really bad due to experience of racism, bullying, and again, not many young Black men want to be said, I'm not a victim. It does add up. It'll come back to haunt them. The stresses and strains of living in a society that's not particularly sort of geared and welcoming will no doubt add a lot of mental strain and pressure on young Black men. But it's not just that. I just get the feeling, and it's controversial in when it comes to young Black male, they don't want to talk about it. You want to be tough, you want to cope, you want to be seen to be weak, and there needs to be more education to say, look, it's okay. Obviously, you'll be really careful who you tell your issues to. Obviously, you don't tell someone's going to take the mickey because they make it worse. So,
yeah,
events like these do a massive favor. It's just start schools, start young. When the problem comes up, and it's got to be culture specific as well. Black men got somewhere to go and to understand and how to cope. Because what we don't want to see is Black men having to solely rely on the mental health system alone. We've got to give them the tools. It's a challenge. It really is. And you need more events like these to help guide this.
I agree. Jason, do you have anything to add to that?
Yeah, I think the things that I would add really is we have to have an honest conversation around cannabis and drug use, I would say. Again, I'm happy to share. So I grew up, I started smoking as a teenager, and I probably smoked for about 10 years. And initially, when I first started smoking, It was like, pure herbs, as you'd call it. And then we started smoking the skunk. And actually, the amount of chemicals that they put into the skunk to make it have that potency is not doing young men any good to smoke that stuff, really. I mean, lucky for myself, I gave up smoking many years ago, but that probably had an impact. And it probably caught up with me later on when I developed my own psychosis. The other thing I would say is it's definitely a stressful time for, and maybe it's just a young man thing again, but again, growing up, we had open war, basically, like gang warfare, right? So I couldn't go into certain areas because, I'd be chased down by a bunch of boys. Right? So all of that stress, that being living in fear, having to kind of, be conscious about, am I in the right area or not? Am I going to be approached by another black man telling me, who am I? Where am I from? Right? All of that impacts on people's sense of self, I would say. And the funny thing is, so I don't live in London anymore. I actually live in Sussex now. And Sussex is a nice area. But what I would say is that I meant to live in Glasgow after I had my psychosis. And actually, when you live in a place where people say good morning to you, it makes you feel so much more better. It makes you feel much more connected to the community. And unfortunately, I think in London, I do try. So when I see another man, I do try and nod at them or say good morning. I do try now. But I know when I was a youngster, I lived in fear of other black men. I wouldn't, unless I knew where you were from. It was beef, basically. and that's just an unfortunate thing. And I know the young boys are going through the same trauma now, actually, because it's getting worse. And actually, we need to do much more to help people see, when they see themselves, they're seeing, a family member, or they're seeing a brother or sister or cousin. They're not seeing their enemy. And I think we need to get much better at that, really.
You've made me think a lot. So I grew up in East London, and we had the similar nonsense with postcode wars, and if you cross the road, then you're in the wrong area and all of that. But I never actually thought how that could have actually had an impact on my mental health until right now. So that's actually really interesting. Thank you for that. Wow. I guess this question, like we talked about it a little bit, kind of. I think Elaine alluded to it, and so did Sarah, and a little bit of Matthew did too. But we talked about, the question is like, what is unique about our experiences as Black people in the UK that leads to us having poor mental health compared to, let's say, the experiences of Black people in the Caribbean or in the African continent? And whoever wants to take it can take it.
I might jump in and just say, I think what everyone is thinking, which is racism. I think we've all talked about it so far, but there is something unique about being a minority, even though we're not. I've stopped using the term BAME or BME and just start using POGM, which stands for people of the global majority, because that's what we are. But unfortunately, we live in a white majority society. I think what's really important, and I'm not sure this point has been stressed enough, I think a lot of the time when we think about mental health in Black communities, we kind of put blame on our communities. We talk about how there's stigma in our communities, we don't speak up, we don't talk. But I think when I'm talking about mental health inequality, when I'm talking about racism within mental health care, I always put the onus back on the system. At the end of the day, it's mental health services and mental health professionals who need to be doing better. Stigma wouldn't exist if there wasn't a traumatic and racist history of mental health services for Black people. Black men are 4 times more likely to be sectioned under the Mental Health Act, and that's their route into care. Black women are more likely to be given psychotropic medication rather than talking therapy and support. And so it's understandable that our communities are not open to mental health, and we're not comfortable with mental health systems because they weren't built for us. In fact, they were built to kind of police and oppress and control us. And so I think it's really important that we acknowledge that. And like I said, when you asked when if talking therapy is for Black people, it can be, but the way that the system is built at the moment means that it's not. And so I think all these things together is what contributes to the fact that Black people in the UK have worse mental health outcomes, worse access to care, worse experience of care, and worse outcomes than our counterparts in our home countries.
That was a brilliant answer. I do not know if anyone can or would like to follow up on that, but does anyone else have anything to add to that?
And I'll be brief. I think it's more than a mental health system, to be honest. It's so many things. Obviously, discrimination, racism fits into it, but you got to mention also, class plays a part. Unfortunately, with ethnic community, just don't have the resources, whether it's on purpose or just not enough support for them. It's just obvious. If you just don't have the resources and the system isn't built for you, it's a one-way conclusion. You're going to suffer, and unfortunately, it's the Black community. Something has to change, but it's complex. I don't think it's an easy thing, really. It just goes so deep. Been around for a very, very long time. There's not going to be a silver bullet or a single answer to this.
And go on, Lynn.
Yeah, I guess so. I wanted to shine a light on there was a review about maybe 4 years ago, something like that, where it shone a light on the inequalities. And then when you look back at it, there were so many reviews kind of talking to different Black people repeatedly saying they were not getting a decent service, and essentially nothing then changing as a result of all of that. I guess I know that NHS England have started something called the Patient and Carer Race Equalities Framework, but it's a bit woolly and vague, and it's not quite prepared, and it's only just piloted. But I guess it's by doing that, I think there's an acknowledgement that there has been racism. There is racism, without them ever directly saying we are a racist organization. And I guess sometimes it is hard to sort of work through a system which I know to be heavily kind of full of disparities for people that look like me, that could be my brother, sister, cousin, and I think it's important for people to pay attention to kind of what people are saying. And I think that is a reflection that they're starting to, but realistically, when we're likely to see any effects of any changes is going to be years kind of down the line. But in the meantime, there's me, there's Sarah, we're there, we're representing people, and we're trying to influence things in the small section that we have influence over. And there are other members kind of staff who are showing that sort of compassion, that interest, and wanting things to be different, although it's going to be hard to show that as a kind of an overarching change.
Thank you. Jason, I'm sorry to come to you last, but would you have anything to add to that?
I mean, the only thing I would add is that at least, so my cultural background is from St. Lucia, which is a beautiful island, and I'd recommend anyone to go if they've not been before. But I think there's just much more love when you're kind of in the Caribbean. It's kind of like there's kind of like a much more warm, kind of cohesive feeling that you're part of. You're not a kind of outsider. You kind of fit in straight away. You're amongst your people, and I guess it can feel quite sad to, as I said, not to have people to say good morning, like to have, because I'm quite a big guy. So, if I'm walking down the street, people will kind of give me the wide berth, right? And I'm actually a really nice, friendly person, but it's just that automatic perception of, seeing someone like me coming towards them. They're not thinking that I'm nice and friendly. And that's just an unfortunate thing that we have to live in a society like that, really, especially in this day and age. But yeah.
Yeah, it's like I'm 6'5", and I am also like a nice person, but wherever I am, particularly if I'm in a hoodie, people think that I'm gonna rob them or stab them or shoot them. So I relate to that too. So I get what you mean. I feel like kind of living in this country, you kind of have this sort of unconscious like feeling that you don't necessarily belong here, because it being like, predominantly white, and then feeling like you're out of place a little bit. So I can relate to that. I'm gonna come to Elaine, and then Sarah. My question is like, what is it like being a Black woman working within mental health? Can it be triggering? Like, say for example, if you see patients with similar mental health conditions to ones you may have, or something like that.
Yeah, I mean, for me, sometimes I feel scared by it. Sometimes I feel tired of it. And occasionally I feel kind of hopeful. um, and I guess I say that. I remember when I'm not from London. I came down here to with my nurse training, and I've worked only in London now. Um, and I went onto the ward and I was just really shocked. There were so many Black people there. I remember being really struck, like, what is happening? And I guess if I knew then what I know now, like, actually, that shouldn't be a surprise to me. Higher rates of detention, higher rates of kind of use of restrictive measures, restraints, seclusion, things like that. And I guess now I know I guess that scene is not as shocking to me. It's quite commonplace, and it's sad and it's desperate, because I'm looking at people that could be my mum, my aunt, my whoever, my friend, and it's hard to watch that. And I also think it also kind of strikes me is that I remember kind of 3 different kind of episodes in my time working as a nurse, and where colleagues have kind of approached me and said, "Oh, I thought you were quite intimidating at first, but then I got to know you." And I'm like, "Oh, okay." So I guess my first and second time I was like, "Well, what is it about me that is giving off that impression?" I'm just I was a little bit kind of, what is it I've done? Well, I can be quite quiet when I first meet people. I'm quite socially anxious. I know that about myself. And it takes a second for me to sort of get, relax and joke around with people and that sort of thing. I was like, well, I'm 5'6", I'm slight. What is it about me that's so sort of intimidating? And on my third time, I realized that each colleague had, like, because I've been working in London, the diverse backgrounds of all the people that I've been working with, so many different people, all of those colleagues have been white. And I began to wonder if it was more about their perception more so than something that I had done. And then it made me think about how that then relates to how they are with our service users, how a snapshot of time in which they're doing an assessment for about their mental health, whether that's for a mental health act assessment, or whether that's just seeing them in the GP surgery or for the initial assessment, how that perception is just a snapshot of time of that person. And if they took the time to get to know them, would they have a different perception of what they thought they had noticed? And that comes out a lot when I remember kind of ward rounds, something, Matthew, you might be familiar with, kind of being in care, but going to ward rounds and when I was a staff nurse and working on the wards, it would be sometimes about making sure that the responsible clinicians, the doctors, the other healthcare professionals have understood that person in the way in which they intended to be understood. So the person may say something, and when we talk about it afterwards, I don't notice that the doctor has a complete different understanding of what I know they have said. So having to make that change and correct that, and speaking up and being able to do that. And I guess not everyone will necessarily feel brave enough or bold enough to do that, but it has to be done. And then from the other perception of going to ward rounds as a care coordinator, where I've known the person really well, so it's easier for me to then interpret, like, say in the ward round with that person there, no, this is what they're saying. Like, I'm just explaining, this is how they've come to this. And it feeling like context is everything. You cannot just lift people out of the context, because you won't really understand what they're saying and how they've come to a position where they're saying it.
Yeah. And Sarah, what's it like for you?
It's strange, but not strange, but I can really relate to everything Elaine has said. And I'm thinking about my journey as a Black woman working in mental health and where my focus has started and where it is now. I think what Elaine said about her experience of the wards is identical to mine. I came in as quite a naive support worker and was so shocked. I worked on a secure female inpatient unit at the Maudsley, and I was just so shocked. Everyone there was West African or Caribbean. I mean, all the service users there was West African or Caribbean, and everyone was extremely unwell. If there ever was a white patient, they'd be in and out within 2 weeks, sent off to a different unit or a private bed. So that was my first thing, and I think, like Elaine said, these women could have been my sisters, my mothers, my aunties, and so that was triggering in that sense. But then I started to notice the patterns within staffing. So whilst all the staff, all the service users were of Black ethnicity, all the nurses and support workers and essentially lower bands in the NHS, so lower paid positions, were all also West African and Caribbean nurses. And if we looked at the senior management, the doctors, the psychiatrists, the people who are making the decisions about these patients' lives, not the people who spend the most time with them, but the people with the power to extend a section 2 to a 3 or to deny leave or, you know, whatever, they were all white. And that really, really bugged me. And I think that started my journey within mental health, still as a clinician, as someone who's really focused on representation of Black staff in mental health services, because I really feel like that's a force for change. Like I said, it doesn't have to be us delivering the therapy, but it has to be us within these services, having those conversations and shaping services so that they're better for our community. So yeah, it's really interesting to reflect on that. But I think also Elaine's point about how you come across as a Black woman. So I've currently muted Twitter because I tweeted my experience of an episode that happened at work just yesterday, where essentially someone had escalated to my supervisor that I seemed very annoyed that someone else was sat in my desk and when we hot desk. And my supervisor wasn't sure whether or not to raise this with me. And I said to her, I was like, I'm really grateful you did, because we need to talk about how that's a racial microaggression. I said, this member of staff has never met me before. They never asked my name. And yet they felt that my attitude, considering we work in healthcare, so we're all still wearing masks, she could only see my eyes. Apparently I had attitude, or apparently that was not acceptable behavior. I should have been softer and kinder. And I said frankly to myself, I said, that's a racialized microaggression. We need to talk about this. And I don't think me of 3 years ago would have done that. But like I said, my shift is on Black staff and getting us into services. And unfortunately, that's not easy, because we also experience racism. We also experience discrimination. We are also harder to progress into more leadership positions so that we can make the changes that we want to do in the services. So yeah, it's a complex one where you see yourself or your family members reflected in the people that you're serving, but you also experience what they do in terms of the discrimination and racism, which means that it's very hard to make the changes that you want to make.
Thank you for that. We lost Jason. I assumed he was gonna come back during the answer, but I'm not sure if he'll return. But it's okay. So my next question, I'll start with you, Matthew, and then we'll go around. But a friend of mine recently saw a Black psychotherapist who explained that because he is Black and that he also has dreadlocks, like assumptions would be made about him if he was to say that he like, I think occasionally or rarely smokes like cannabis. So like if he said that during his psychiatric assessment, she suggested the stressing the point that his mental health crisis was not drug induced. And with all of you, do you find like within your work you have to like help Black clients navigate the system in similar ways like that?
I mean, as I mentioned before, one of the big reasons, there's several reasons, but one of the big reasons I set up, the BAME Care Forum, and I know BAME's not out of fashion these days, but it started off as that. Obviously, going to change the name at some point. Was to educate and get carers from that background to understand and hear and also hold to account how they are represented in regards to fighting for their loved ones, because they're going to experience the people second guessing. I think I don't know if it's unconscious bias. I think it's sort of related to that within the system. And unfortunately, the outcomes will be poor when people make these sort of preconceived notions. And when these things keep happening, obviously, the community are not going to really want to get an engagement into it. They're not going to want to care, not going to want to know. And then, unfortunately, at some point in their life, they may experience mental health needs. You're going to have to rely on what you call a system that's struggling and broken, even before it comes to these notions of unconscious bias. We've got to remember the mental health system as it is isn't really that supported. They call it the Cinderella service for a reason. So it's not even that well supported or funded that well. So there's a lot of issues with it, a lot of issues. So, but that's one of the reasons, I formed that sort of group, even though the focus was on families and carers.
Sarah?
Yeah, I was thinking about this question. I find it really interesting because I was reflecting back on my experience of working with people therapeutically. And unfortunately, besides working in the inpatient unit that I described earlier, I haven't come across that many Black clients. And again, I think that speaks volumes about the access to services. For example, at the moment, I'm working in CAMS, so child and adolescent mental health services. And there does seem to be a pattern of who meets the threshold and who gets seen in CAMS. If we think about IATs, improving access to psychological therapies, again, there's a pattern of who gets access to those kind of services. So when I do come across people from Black backgrounds or non-white backgrounds, I think not necessarily helping them navigate the system, because it took a lot for them to get to the chair in front of me. Getting access to therapy in the NHS is not easy. I think what I focus on is making sure that they feel empowered and heard within their experience of therapy, and recognizing whether it's racial trauma, what it's like to be born in this country but not feel like you belong in this country, experiences of migration, experiences of community stigma, whatever it is, different languages. I think just making sure that they feel comfortable and that there's a safe space for them to talk about those things, I think is my way of maybe helping them navigate services, or at least have a positive experience of services. What I do with most of my clients is something called a Genogram, which is kind of like an extended family tree. But I really pay attention for people from Black communities or non-white communities, really paying attention to migrational history and generational history, and how things might change from your generation to your parents' generations because they migrated from a different country, and what that experience was like for them, and what is it like for you. So yeah, it's sad to reflect and think that I haven't come across that many Black clients in my work, apart from within the inpatient unit. But unfortunately, like I mentioned before, that is because of how the system is set up.
Elaine?
Yeah, it's hard to add kind of any more kind of salient points than that. But I guess in my specific experience, I guess I've never maybe been as explicit as kind of what, the example that you mentioned there. But it might be about kind of talking to someone about the ways in which people can sort of write notes or think about them, and kind of advising people in terms of, people don't always take into account all of the narrative when they are saying something about you. For instance, if someone is kind of, standing by the door, like for instance on the ward, I give that example, if they're standing by the door and saying they want to go, all that might be written in their notes is they're saying they want to go and they're standing by the door and they're obstructing other people from using it, as opposed to that they said beforehand they were very scared, they didn't know what they were doing there, they've been taken here and their understanding is they don't want to be in this ward and they haven't really agreed to it. If you don't put all of that narrative in there, then all that is in their notes, or all someone else will come across is that the fact that they're banging on the door and asking to leave. And I think it's so important to keep that context there. And I guess when I think about it, all I can really do is to carve out within the services that I operate in the best way to sort of understand that person, that allowance, that hearing people, listening to people, responding to what they want to get out of the service, instead of kind of prioritizing all the other kind of bits of what the role's supposed to entail. And that's ultimately kind of what has to happen. And I guess it's like the service, NHS particularly, are so reliant on the goodwill of people to offer up their own time to help make this happen, more so than actually putting in directives to encourage that behaviour in general. And I know that they are kind of making sort of piecemeal attempts with the patient carer and patient carer race equalities framework. However, it's been such a long time coming. I can see why there's still skepticism in terms of people taking that up and doing anything with that.
Okay, I'm very conscious of time. We have 2 questions left. I'm not sure if I'll be able to take any that came in, but my first question is like what can we do to prevent service users from repeatedly returning to mental health services, especially after psychiatric interventions?
Well, from my perspective, I'm heavily more focused regarding the support for unpaid carers and families. They need that support. So that, because at the end of the day, they're going to be the ones going to provide that care and support for their loved ones, regardless of the mental health system being there. So unfortunately, for my sort of focus is that do not forget the carer, be it with the black, white. That is my main focus. I'm not a mental health professional, without that. And I'm sure you need someone who's clued up on policy or whatever. But from what I've experienced, the carer must not be forgotten, because they are part of that important tool. So that's my view on that.
That's very valid. I think you're spot on. Sarah?
I don't have an answer for this one. I really don't. I really struggle with this question. Like Matthew mentioned earlier, the mental health system is very broken. So it means that often people are returning. Often the treatment either that they got what didn't work for them, whether or not that's medication or even if it's a particular type of therapy. And they go back to, if we think about the social element and the social factors that increase kind of mental health stress and pressures, they're going back to the same environment. There's so much beyond mental health care. It's also social resources, housing, employment, all that kind of stuff. Mental health system sometimes feels like a band-aid on a very, very big, broken leg, essentially. Like it is really difficult.
Sorry, I've just seen that Claude Roberts has said they really appreciate us talking about this issue, and thanks you all. Elaine?
I'm not sure how much I can really sort of add to that. I think Matthew's point there about kind of really sort of shoring up and skilling up carers and taking that time to to spend that time with them, because ultimately they are the people that are going to follow this person right the way through their journey in terms of mental health. Realistically, services are a snapshot in time, and ultimately it's the people that are meaningful in their lives that are really going to have an influence. And I know that people who have social networks tend to do better in terms of their mental health than people without. So for sure that, again, like Sarah, there's not an easy answer here. I think so many things are kind of at play. I'm aware that like 50% of mental illnesses start before the age of like 14. So, if we really want to go at it, it's probably a preventative thing that we really need to invest properly in, and CAMS especially, which is constantly money is being withdrawn from that area, and it just doesn't make sense. And then, of course, people getting access to these services, they are there, and they're supposed to be there for everyone to access, and that's not always the case. So all I can suggest is kind of greater representation sort of at the top. No, not so much of this snowy white peaks nonsense. People getting invested in a real way. Maybe that means bringing in policies if people can't just be invested because it's the right thing to do. Maybe it's about kind of skilling people up, skilling up communities, rather than necessarily if people are reluctant to come into mental health services for very valid reasons, for genuine reasons, like have been mentioned, like that concern about side effects not being taken seriously, Black people not being listened to. Understandably, people are not going to want to access a service they think is like that. So it might be about outreach and changing the perception and saying there are people out there that will listen and care. It's hard to say, it's hard to give one answer.
It's very broad. Well, I guess that in itself is the answer. There's too much. I just for the final question, I just wanted to ask everyone, like, what do you think is one thing that you would suggest for Black people to do in order to take care of their mental health?
Simple one, because it needs to be simple. Just be kind to yourself, and try and be kind to each other. We've all, you can't really judge a person if you're not on their shoes. Not that you want to wear in on shoes anyway, but we need to be kinder to ourselves and those on the same gender as us. We're experiencing discrimination, racism. Why be mean to people that are sharing that really difficult road? Is tough, really tough. We've got to be kinder to our community, and education is part of the key. So more events like this helps educate others. Okay. That's me.
Sarah?
I think just to add on top of what Matthew just said, I think community is really important. That I think there can be healing and comfort found within community, whatever community looks like for you. It doesn't have to be kind of, ethnicity based or whatever, but finding people who have shared experiences that can affirm and validate what you've gone through, what trials and tribulations you've gone through, I think can be really powerful.
I'm just seeing Samantha's message of, as a parent of a service user who has opted out of the mental health services, they believe to stop patching people up and sending them out, whilst other people get therapy and I guess get the help that they need. Elaine, final point.
Yeah, I guess just to add on to what's already been said, like talk to someone, talk to a trusted friend, a relative, talk to your GP, a professional, talk to someone on a mental health advice line. Don't hold it in and keep it in that way. And I think that really kind of can influence the course of things for people. I think it's an incredibly powerful thing, a powerful demonstration of self-care to ask for help when you need it.
Agree. Okay, so we went over a little bit. But I guess this is all we have time for. Thank you to all of my guests for joining. You're all incredible. I feel like I could talk about this for hours, to be honest with you. But I really appreciate you giving up your time and your evening to come and talk to us. So thank you, and enjoy the rest of the evening. Bye, everyone.
Thank you.